I introduce the first speaker is Dr. Lazar Davidovic from Belgrade, Serbia, and he's going to talk about a rational indication for open or endo management in Juxta pararenal aneurysm.
Thanks so much. I would like to thank Professor Alonso and Professor Silva for inviting me once again to this more than prestigious symposium. I'm sure that organization was very great challenge because of extreme floods in South Spain. At the beginning of my lecture, allow me to remind you briefly on the difference between juxta and pararenal aortic aneurysms. Namely, according to new reporting standards from the current TSVS guidelines, juxtarenal aneurysm has infrarenal neck shorter than 4 millimeters, and it does not involve renal arteries. On the other hand, pararenal aneurysm has no infrarenal neck. It involves at least one renal artery, but does not involve SMA. Open repair of both juxta and pararenal aneurysms is performing under suprarenal aortic cross clamping, but open repair of pararenal aneurysms requires a procedure with at least one renal artery. That is the difference. What is the first choice for the treatment of juxta and pararenal aneurysms? Open surgery, CHIM, NIVAR, or FIVAR? Opinions are divergent. According to some of these studies published during the last decade, there is no significant difference regarding 30-day mortality between complex open and complex endovascular repair for juxta and pararenal aneurysms. At the same time, open repair was associated with higher risk of perioperative myocardial infarction, acute renal failure, and pulmonary complications. But some newer studies found better early outcome after complex endovascular repair for juxta and pararenal aneurysms. What about midterm results? These meta-analyses didn't find significant difference regarding midterm aortic-related mortality between complex open and complex endovascular repair for juxta and pararenal aneurysms. At the same time, endovascular repair was followed with higher rate of midterm aortic-related reinterventions. In the following part of my lecture, I will present you results of our 3 studies dedicated to the same problem. The first of them is this retrospective cohort multi-center study with 834 consecutively treated patients in 6 high-volume European vascular centers. No difference regarding in-hospital mortality as well as 30-day mortality and overall survival after 87 months of follow-up between EVAR and open growths was found. Patients underwent endovascular repair required more frequently aortic-related reinterventions, while those underwent open surgery more frequently have developed acute renal failure. But most of these patients with acute renal failure recovered completely without additional progression of renal function. Results of our 2 meta-analyses that compared short and mid-term results after open repair, CHIVAR and FIVAR of juxta and pararenal aneurysms follow. All comparative studies with 2 or 3 treatment options published before July 1st, 2022 were included in this meta-analysis. Studies with standard infrarenal AAAs, then studies with infected, ruptured, suprarenal, connective tissue-related AAAs were excluded. We excluded also studies with less than 10 patients per treatment to ensure adequate experience, as well as studies performed before 2010 to reduce the number of different stent grafts in comparison. Primary outcomes of our first meta-analysis included investigation of 30-day mortality, acute renal failure, boil ischemia, as well as major cardiovascular complications. Secondary outcomes included analysis of several different 30-day complications. During our first meta-analysis, 1,553 publications were identified by the search strategy, of which 62 had full text. Out of them, 22 non-randomized observational studies with 8,853 patients were included in qualitative analysis. More than 5,500 patients underwent open surgery, more than 2,600 underwent fever, while almost 700 patients underwent Shiva. Majority of studies reported outcomes for juxtarenal aneurysms, 4 studies for juxta and pararenal aneurysms, while 1 study reported outcome for pararenal aneurysms. According to our first meta-analysis, fever and Shiva were associated with lower 30-day mortality, boil ischemia, and major cardiovascular complications rates in comparison to open surgery. At the same time, fever was associated with a lower 30-day acute renal failure rate, but with higher 30-day spinal cord ischemia rate compared to open surgery. During our second meta-analysis, 1,723 publications were identified by the search strategy, out of which 16 studies were included in the network meta-analysis. The mean follow-up period was 31.4 months. Primary mid-term outcomes in our second meta-analysis were total mortality, aortic-related mortality, as well as aortic-related reintervention, while secondary outcomes included visceral stent or bypass occlusion, major cardiovascular complication, new onset renal failure, as well as development of different types of endoleaks. And according to this second meta-analysis, fever was associated with higher total midterm mortality in comparison to open surgery, but no difference between different treatment options was found in terms of aortic-related midterm mortality. Fever and Shiva were associated with higher rate of aortic-related midterm interventions. Then fever and Shiva were also associated with high rate of midterm visceral branch occlusion or stenosis, but there was no difference between fever and Shiva regarding that. Finally, there was no also difference between Shiva and fever regarding development of endoleaks. Ladies and gentlemen, our 3 studies suggest that high-risk patients with juxta and pararenal aneurysms might benefit from complex EVAR, while good-risk patients with long life expectancy might benefit from complex repair of juxta and pararenal aneurysms. Current TSVS guidelines recommends also that patient's status, namely associated comorbidity, then aneurysm anatomy, and finally patient preference should be considered during the decision-making process regarding the treatment of juxta and pararenal aneurysms. I disagree with patients' preference. Namely, in my opinion, patients and their relatives should be very precisely explained treatment option, recommended treatment option at potential complications, but only experts should discuss about that and should decide about that. Both open and endovascular repair for juxta and pararenal aneurysm should be performed only in high-volume aortic centers. But the question is, what does exactly high-volume aortic center mean in contemporary practice? For instance, according to these American guidelines, an elective open repair of standard infrarenal AAAs can be performed at centers with an annual volume of at least 10 procedures per year, and with documented perioperative mortality of 5% or less. My comment is, how is it possible to guarantee such good results, such low perioperative mortality with such small experience? In my opinion, that is impossible. And due to this, as one of reviewers of previous European guidelines, I insisted on the higher annual hospital volume, 30 procedures per year. Finally, current ESVS guidelines recommends that both complex open and complex endovascular repair of complex AAA should be performed in centers with volume not less than 20 procedures per year. Thank you so much for the attention. Thank you.
Yes, it's okay. Next talk will be anesthetic remarks for open repair of thoracoabdominal aortic aneurysms from Vivek Sharma.
Hello, everyone. My name is Vivek Sharma. First of all, I would like to extend my thank you to Dr. Alonso for inviting me for this wonderful conference. I'm an anesthetist, and I'm the lead of ICU at Bart's Heart Center. And following the previous conversation, the excellent talk, I would like to say that we perform close to 50 to 60 open thoracoabdominal aneurysms a year. So this comes from a little bit of experience from our end. I have no financial disclosures. All I want to say is a big thank you to all my colleagues who participate in the open thoracoabdominal aneurysm program because it is brutal. That's a view of St. Paul's Cathedral. That's our hospital. It's a bright sunny day in London, pretty much similar to the weather out here. Okay, that's always the case in London. Don't believe the stories that it's dark, gloomy. London is beautiful. So the key principles of open thoracoabdominal aneurysm repair is to prevent organ dysfunction, spinal cord protection, multimodal monitoring, and enhanced recovery. We do this as a 2-person procedure. There's a consultant anesthetist who starts the case. Then at around lunchtime, when we are going on to left heart bypass, someone else joins in who's another consultant anesthetist. We overlap for the period of left heart bypass, and the first person leaves at around 7 or 8 in the evening. The second person who's coming at lunchtime finishes the case. It is quite a labor-intensive case from our end because in terms of lines and monitoring, it's the full Monty. We just throw the kitchen sink at these people. We start off with a wide bore cannula on the left side because they are all done in the right lateral position. For the proximal pressure monitoring line, we have a right radial and another vascular access on the right side. We've got a VasCath, which is a dialysis catheter in the right femoral vein for rapid transfusion of IV fluids, and a femoral arterial line for the distal pressure monitoring. Patients are intubated with a double lumen tube. There is a central line on the left IJV. There is a Swan-Ganz that goes in on the left IJ. There is neuromuscular spinal cord protection monitoring in terms of a CSF drain, NERS, depth of anesthesia monitoring, the urinary output catheter, and a TOE probe. So all this takes us the best part of an hour to get this set up. That's a bird's eye view of the chaos in our theater. It might not be very visible over here for you, but the next slide will probably make things a little bit more clearer. So that's the view from my end. That's the TOE machine. That's the Belmont rapid transfuser that can give up to 750 mLs of IV fluids a minute. That's our CSF drain. I've got 10 to 12 infusion pumps, a double lumen tube, That's over there, the TOE probe, infusion pumps, my anesthetic machine, depth of anesthesia monitoring. We move over to the surgical side, and that's the motor evoked potential monitoring on that end. So in terms of monitoring, starting from head to toe, we have a cerebral nurse and a somatic nurse. We have a depth of anesthesia monitor, which allows us to titrate the anesthetic agents because we don't want the anesthetic agents to interfere with the motor evoked potentials. We have a CSF drain. So that's the CSF drain, which is connected to a Leica guard, which is an automated CSF drainage kit. It's set at a pressure of 10 millimeters of mercury, and it drains around 20 mLs of fluid an hour. That's the motor evoked potential lady. She is like my mother-in-law. She just complains about absolutely everything. Every 5 minutes she comes up to me and says, have you changed anything in the anesthetic? Have you changed anything in the anesthetic? That's the somatic nurse, that's the paraspinal nurse, those are the head electrodes, depth of anesthesia, and head nurse. I'm not going to talk much about the spinal cord blood supply because this is the wrong audience. You people out here know much more about this than I do. But the gist of all of this is that following the publication by Eva Gribbs in 2012, we established that the collateral network is probably more important than the artery of Adam Kivick's. And we try our best to maintain a spinal cord perfusion pressure of more than 70, which is the mean arterial pressure minus the CSF pressure. Things that increase the spinal cord, the pressure in the CSF are the aortic cross clamp, cord ischemia, and obviously the spinal cord drainage helps alleviate this pressure. This is our data from BARTS, around 99 to 100 spinal drain insertions over the past 4 years. Everything that can go wrong has gone wrong. Okay, you name a complication and that has happened to us. We've lost a catheter inside the spinal cord. We've not been able to cite the spinal drain in a couple of patients because of the extreme kyphoscoliotic nature. We've had to call interventional radiology to cite in a spinal drain. Luckily for us, the major complications, which is subdural hematomas, intraventricular hemorrhages, have been quite low, and they've all been conservatively managed. We've had 2 cases of Press syndrome, which is the posterior reversible encephalopathy, and again, they were conservatively managed. The eternal blood pressure tug of war. The proximal pressure has to be maintained at around 130 to 150 millimeters of mercury with a spinal cord perfusion pressure of more than 70. We use GTN with the proximal clamp going on. At the same time, when we start losing blood, we have to replace calcium, so they all act together and in different ways. Somehow it works. The distal perfusion pressure is maintained at around 60 to 70. And why am I talking so much about perfusion pressure? Because ultimately what happens is you've got hypoxia, hypercapnia, and the application of PEEP due to one lung ventilation. You've got circulatory overload and massive transfusion due to the ongoing losses. And when I say ongoing losses, we recirculate up to 20 to 100 liters of fluid back to these patients. And we've got metabolic acidosis. And all that results in the perfect storm and leads to that. So we've started preempting RV failure, and we've taken some steps to alleviate that. So what we do now is, that's a struggling RV. We start the patients on a low dose of adrenaline. We give them some glycopyrrolate, and that has massively helped us. We intubate with a left-sided double lumen tube, and that's an elegant video, which I'm about to show you of how the tube goes in. Bear in mind, please, this is a pre-operative video. And at the end of the procedure, the lung doesn't look anything like this. This is pristine, this is beautiful, and which is why I'm presenting it to you. Okay. In around 5% of our patients, due to the effect of the aneurysm, we cannot put in a left-sided tube. So we've had to put in a right-sided tube. And that's what it looks like at the end of the procedure. the next slide, that's the view of our trachea. That's the double lumen tube at the end of it. That's the upper airway edema. And in up to 18% of our patients, we cannot change the double lumen tube to a single lumen tube at the end of the procedure. So we take them to ICU with our double lumen tube. It's not uncommon to have a chest X-ray like this at the end of the procedure. That's what happens after 15 rounds of boxing with Mike Tyson. And no one wants to wake up. We try all lung protection strategies, tidal volumes of 4 to 5 mLs per kg, maintaining a plateau pressure of less than 30 with a driving pressure of 15. And we've come up with some really clever interventions because of the bleeding, and this is one devised by one of my colleagues. So that's a CPAP applied to the non-dependent lung with suction inside the lumen, and we are sucking on it while the blood leaks out from the lungs. Acute kidney injury was a big issue at Barts, and we introduced a care bundle. We stopped dehydrating patients at the beginning of the operation. The surgeon started using custodial solution in the renal perfusate. We introduced a combination of dexmedetomidine, mannitol, furosemide, and with the help of this, we managed to make massive strides in reducing the risk of acute kidney injury. We used to have up to an 80% rate of stage 2 to stage 3 AKI. And after implementation of this care bundle, we dropped it down to 40%. We had a 0% rate of renal replacement therapy at the end of the procedure, whilst in the pre-bundle patients, we had a 12% rate of renal replacement therapy, as in dialysis. Lastly, our patients bleed a lot. We try everything in the book. So that's some platelet-rich plasma that we harvest at the beginning of the procedure. We have an algorithm guided by TEG, which tells us how much to transfuse. We use all synthetic products to reduce the amount of volume we are giving our patients. And finally, it's all about multimodal monitoring, spinal cord protection, RV protection, early detection of hypoperfusion, and the power of the bundle. Thank you.
Thank you, Dr. Sharma. We know that Dr. Davidovic has to go, he has to go, but we have two comments or two questions for you before you leave us. First of all, in our environment, because you have explained perfectly your approach to the Juxta renal, how to do the open repair in so many cases, but here in Spain it's so difficult to convince a patient fit for an endovascular therapy that it's preferable to do an open surgery. Every day is more and more difficult because people used to read and even to choose with therapy for them. So some recommendation in this point is in your vision?
First of all, young generation of vascular surgeons should be educated for both procedures, open and endovascular, including anesthesiologists as well. Due to in my clinic, anesthesiologists, cardiologists, together vascular surgeons are every day included in discussion about treatment options. Due to this, we have really huge experience with open aortic surgery, but thanks to new hybrid room, I think that in the future we will increase the number of complex endovascular procedures. One of them, my younger colleague, Associated Professor Conchar, has initial education in Professor Riambau Hospital. Now we have one another doctor in Professor Gargiulo Hospital, but at the same time, the third of my colleagues had education in San Raffaele. That is our formula.
From the floor, any questions from Dr. Davidovic? I would like to ask you about CBAR. what do you think about TIVAR? What do you think the place, the role that it has nowadays?
I'm not endovascular expert, so I cannot answer precisely on your question. According to my opinion, the vast majority of endovascular experts would like to use and to perform TIVAR in such cases. My clinic has not significant experience with TIVAR. It was, I told during my lecture, it was multi-center study that included 6 high-volume centers. Some of them are dedicated to open surgery, some to endovascular surgery.
Thank you.
Thank you. Have a good trip.
Thanks so much.
We release you.
Sorry.
Thank you. Next speaker is Dr. Luis Baeza Alvarez. He's another anesthesiologist from the UCA hospital, and he's going to talk about current controversies regarding the CSA drainage protocol. Thank you, Doctor.
Good afternoon, everybody. I'm Luis Baeza from the Department of Anesthesia and Intensive Care here at Hospital Universitario Central Asturias. First of all, I would like to thank the Department of Vascular Surgery for inviting me to speak here today. The topic that we are going to discuss in the next few minutes is clinical controversies regarding the cerebrospinal fluid drainage protocol. I have no disclosures to discuss with you. So the current controversies that we can see in the literature nowadays is this four. Is CSF drainage a safe technique? Should we use prophylactic CSF drainage in open surgery? Should we use prophylactic CSF drainage in endovascular surgery? And do we need a standard protocol to prevent spinal cord ischemia? As we all know, spinal cord ischemia is a devastating complication after surgery. It is said that for open repair, a patient who suffers spinal cord ischemia has a perioperative mortality of almost 50%. In TIVAR, 12-month mortality for a patient who suffers spinal cord ischemia is 85%. Regarding to this, some strategies has been promoted to reduce the rate of spinal cord ischemia, such permissive hypertension, hemoglobin optimization, naloxone infusion, corticosteroids, mild hypothermia, and cerebrospinal fluid drainage. That to date is the only one that is supported by randomized controlled trials. Actually, it's a Class 1A from the American Guidelines for Open Surgery, published in 2022. And it's an evidence Class 1B for open and 2C for endovascular in the European Guidelines, published in July 2024. The first question is cerebrospinal fluid drainage safe? Okay, cerebrospinal fluid drainage is an invasive technique that could be related with important complications. The most up-to-date and important study regarding this is this one published in British Journal of Anesthesia in 2018. It's a study that is a systematic review and meta-analysis that enrolled more than 4,700 patients across 34 observations studies, and they found that the pulling event rate for any complication is 6.5%. They found also that the mortality related with this technique is almost 1%. The rate for severe complications is 2.5%, for example, for MRS and epidural hematoma, that both are devastating, is 1%. The rate for moderate complication is 3%, but there are some strategies that have been proposed to reduce these risks, but like avoid overdraining, placing the spinal drain the day before, and targeted cord pressure. The second controversy is, should we use drainage in open thoracoabdominal aortic surgery? To date, the most single-center series of thoracoabdominal aortic aneurysms is Baylor in Texas, the center where Dr. Coselli spent most of his career. And in this area of 3,300 patients, the rate of paraplegia was almost 10%. Regarding to this, in the literature, we have 3 randomized controlled trials. The first one published in 1981 by Crawford. They drained 50 ml of fluid without pressure control, and they found no benefit in the rates of spinal cord ischemia. In 1998, Svensson drained a larger volume, a mean of half a liter. They found benefit to reduce the spinal cord ischemia. And the last one, it was by Coselli. They drained to pressure, and also they found benefit in reducing spinal cord ischemia using this technique. The third question is, should we use CSF drainage in TBAR? The last publications about that, they found that the rate of spinal cord ischemia in endovascular aorta surgery can be as high as 17%. In 2021, a survey of the United States Aortic Research Conference, investigators found that the 70% of surgeons use prophylactic drains in patients that are in high risk for spinal cord ischemia. But in 2018, this is the latest publications about this topic, is also a systematic review of 28 retrospective studies. They enrolled more than 4,000 patients, and they found after endovascular surgery, they found no benefit in the outcomes of prevent spinal cord ischemia in this systematic review. But in the last few years, the United States Aortic Research, they thought about if there is clinical equipoise in starts a new randomized controlled trial about use or not cerebrospinal drainage in TBAR. And the first one has been led by the group of Adam Beck. They published in July 2024. This is a pilot trial comparing prophylactic versus therapeutic cerebrospinal free drainage. They enrolled 20 patients for repair of either stent 1 to 4, but this study was not designed to identify any clinical differences. The primary outcome was to look for feasibility in identifying and enrolling patients. So we probably see in the next 2 or 3 years a new study about this topic. And just to finish, so do we need a standard protocol to prevent spinal cord ischemia? So in the hospitals around the world, they have published different protocols to prevent spinal cord ischemia regarding his experience. But these protocols are usually different between them, so we cannot compare outcomes. But what is very interesting is this study, also by the group of Adam Beck. They implement in his hospital a protocol to try to reduce spinal cord ischemia. It's a retrospective single-center cohort study, or VBAR, and they found that after implement this protocol, they found that for all patients, the risk for spinal cord ischemia drops from 13 to 3%. In high-risk patients, this drops from 19 before the protocol until 4% in high risk. So this reduction in spinal cord ischemia was also associated with improvement in 1-year survival. So where the conclusions are, is cerebrospinal drainage a safe technique? Probably yes, compared with the risk of spinal cord ischemia. Should we use CSF drainage in open thoracoabdominal aortic surgery? Yes, we have 2 randomized controlled trials about that. Should we use prophylactic drainage in endovascular surgery? We don't have enough evidence yet, but we will see in 2 or 3 years. And if we need a standard protocol, absolutely yes. Thanks.
Next talk will be how to decrease cerebrovascular complication during endovascular procedures. From Luis Miguel Salmerón.
Thank you for this kind invitation. It is a pleasure to share this interesting meeting. Gracias, Manolo, por tu amable invitación. My topic is how to decrease cerebrovascular complication during endovascular procedures. So in this paper, they present more than 41,500 EVARs, 1,300 complex EVAR, and 4,600 TEVARs. So the rate of stroke, of course, is higher when more complex is the procedure. So in complex EVAR, is only 1% of the cases, and in TEVAR, is almost 3%. In multivariate analysis, when they use our axis, the odds ratio is 8.4. And in TEVAR, more proximal landing zones were associated with higher risk, is logical conclusion. So in zone 0, zone 1, the OR is 6.3. In this paper, they say that EVAR has lower rates of prospective mortality and morbidity. So the patient has postoperative dialysis, paralysis, and stroke. In this case, they have almost 500 arch repairs. Is the same conclusion. The rate of stroke is in TIVAR 6%, and the arch repair procedures is 14%. And they found 3 risk factors for a higher risk of stroke when the aortic diameter is more than 65 millimeters, when they use parallel grafting, or when patients suffer chronic kidney disease. This is a multi-center retrospective observational cohort study with 255 patients. And they have these figures, and the rate of stroke is more than 3% of the cases. They made a binary logistic regression analysis, and they had 2 conclusions, 2 situation of risk. Is in grade 3 and 4 aortic arch and atheroma. The OR was 6.6, and in shaggy aorta, the OR was 12.1. So this is in this graphic, you can see the different mortality and morbidity, and the stroke is higher, of course, when you are working in the aortic arch. So a stroke in arch endografting, higher rate with endo than in open in some series. Why? Because the endograft deployment across the arch is dangerous. We have to think about air embolism risk, and sometimes we have to cover and manipulation supraortic trunks. Of course, risk increase with more proximal pathology. And one important thing is the impact of volume and expertise of the endovascular teams. In this paper, they present result of aortic arch repair by TIVAR, and you can see in the group A of first 10 patients, very high rate of stroke. But in the group B, following 28 patients, the stroke rate decreased till 7 and 3.6%, around 10% of the cases. With more experience, less complication. Another thing is the device and the procedure. In this paper, they compare different procedures and different endografting in the aortic arch, and they found that the Nexus aortic stent had less mortality and less rate of stroke, only 3.6 of the cases. Why? Probably because Nexus 1 is a specific endograft for aortic arch, and the manipulation of supraortic arch is minimal. Of course, you have to make before a carotid, and carotid subclavian bypass, but the manipulation is minimal, and you have to go up with the endograft with the through and through from the right femoral artery to the right subclavian artery, and is of course the risky of embolism is lower. So we have to wait what are going to happen with the next generation of the Nexus, like Nexus Duo with one inner branch for left subclavian artery, or Nexus 3 with another inner branch. But in this case, the manipulation probably it will be minimus because the inner branch are precannulated. And another important thing of this endograft is the catheter of the endograft is preformed, and it is more easy to go up with the endograft through the aortic arch, even when you have a difficult anatomy of the arch. And another important thing is the flushing procedure. So this endograph has 2 flushing ports, and at the end you have to make a simultaneous flushing. That way the turbulence and bubbles, it will be lower. Air embolism is important. In this experimental study, they looked that when in the deployment of the endograph, there is a lot of bubbles, and not only in the distal part of the endograph, even in the proximal part. So the risk of embolism is high. In this paper, they study the benefit to make flushing with CO2. Of course, it is not cost effective to use a CO2 pump only for flushing. But for example, we use very often CO2 for EVAR procedure. So if you have the CO2 pump, you can use this system. They flush with CO2 for 5 minutes, followed by 6 cc of saline, and they saw significantly reduce of amount of gas. Thank you for your attention.
Thank you, Dr. Salmerón. And the next speaker is again Dr. Colin Bicknell from London, St. Mary's, and he's going to talk about what do we know from the UK COMPASS trial.
Thank you very much. This is supposed to follow Lazar's talk, obviously. He's gone, so I can criticise what he said as well without fear of him hitting. So these are my disclosures. I guess I have potential conflicts of interest because I was a co-investigator for the COMPASS grant, and I'm clinical lead for the UK National Registry from this month. So the rationale from the study, first of all, up to 1/3 of aneurysms have a short neck or are anatomically unsuitable for standard EVAR. And at the time of writing, and probably now, there is no robust evidence to guide physicians as to which approach is best. The comparisons before UK COMPASS were, I'd say, invalid because of healthy patients getting open repair, unfit patients getting fenestrated repair, perhaps, and anatomical differences. And the definition of juxtarenal aneurysms is not clear in any meta-analysis. It's something that bugs me every day, that a 4-vessel fenestrated can be a short-necked infrarenal graft. So, because of the lack of evidence, actually it was Raoul Vanabonani conducted a workshop in the UK that looked a bit like Parliament. He asked the question whether or not a randomised controlled trial comparing open surgery repair against FEVAR would be supported, and the vascular surgeons in the UK were absolutely unanimous for once that it would not be supported because we didn't have equipoise. So, because of that, and because that randomised controlled trials don't assess the real world and a trial would neglect anything else apart from FEVAR and open repair, the UK COMPASS study was kind of half-born. Costs for the NHS, of course, are also a significant concern. We all know about the costs of EVAR from the NICE analysis of EVAR, and it's really not cost-effective to do endovascular repair as things stand at the moment. So the research question identified by our national research body was, what is the clinical and cost effectiveness of strategies in the management of juxtarenal aneurysm, including FEVAR? And I think that question was very relevant at the time and is highly relevant in the UK even now. Our National Vascular Registry shows a significant number of complex repairs in the UK. That's not just pure juxtarenal, but others as well. And there is considerable variation, with some centres almost purely endovascular, and some centres way over 50 or 60% open repair. So the variation is very important. The study design of the UK COMPASS trial was a prospective cohort study comparing clinical and cost effectiveness of these different management strategies. What it did is it took routine data from our National Vascular Registry and our hospital episode statistics, our administrative data set for costing, in patients from those years. And it took all of the CTs that were downloaded and put them into a core lab analysis. There are also aims to do quality of life and outcomes, but I'm not going to talk about that. The analysis was a propensity analysis, accounting for physiological and anatomical variables for the first time. And patients were stratified due to aneurysm neck, 0 to 4, 5 to 9, greater than 10, and because of their operative risk. And that's how this data is presented. Primary outcome was, of course, perioperative all-cause mortality. So the patients were included are here, sorry, but they're basically patients who have a juxtarenal aneurysm unsuitable for EVAR. And over those years, there were 8,944 aneurysms in the National Vascular Registry, 2,757 that were juxtarenal or short neck, according to their after core lab analysis, and 1,916 patients included in propensity score matching. So it's nearly 2,000 patients in here. And these are the headline figures over on the right-hand side. The overall mortality is 3%. It's 4.5 for open surgery and 2.2 for FEVAR, 1.2 for the simple standard off-label EVAR. Mortality at 3.5 years, though, is reversed. Open surgery, 14%. EVAR and FEVAR, 25 and 27%. That's overall. The interesting bit is when you start to look at it bit by bit. So that's the Kaplan-Meier curve overall, saying exactly what I said. Overall, there's a higher mortality to start off with and a significant increase, advantage to open surgery later on. It mirrors the EVAR trial over 8 to 15 years, but just draw your attention to here. This happens past 12 months rather than 12 years. If you look at these set of graphs now, this is for 0 to 4 millimeter necks. And on the left-hand panel, it's standard patients. On the right-hand panel, it's high-risk patients. And what you can see is open surgical repair in blue has a significant perioperative mortality. And then there are similar survival rates for open surgery and FEVAR as we go further down. It's much worse in EVAR. What you can see in the high-risk group on the right-hand side is that everybody has a poor survival, and there's no difference between the groups. For 5 to 9 millimeter necks, there is no difference at surgery between open surgery and FEVAR and the other techniques, but there is a difference as you get out to 24, 36, 48 months. Open surgery patients do much better. Again, high-risk patients, no one does well. For the 10 millimeter neck, the high-risk patients, no one does well. That's a common theme. For those patients with greater than 10 millimeter neck, remember these are in the study because they're highly angulated or conical or some other reason why they're not suitable for EVAR. For those patients with the open repair, there is no disadvantage to doing them open in the perioperative mortality, and they do much better long term. Freedom from re-intervention, I think you can guess. Those patients who have open surgery don't need intervention. FEVAR next, and then those patients off-label EVAR need far more interventions going. Sorry, EVAR next, and then FEVAR is at the bottom. They survive longer and they get all those problems. So overall, endovascular treatment is safer in the perioperative period, but benefit is lost after 2 years if you take that 0 to 4 millimeter neck. Re-interventions, though, are significantly higher. Sorry, that's overall. For FEVAR, it's certainly advantageous over open surgery repair in the perioperative period for 0 to 4 millimeter necks. That mortality benefit is lost, and they have similar outcomes later on, but more re-interventions. For greater than 4 millimeter necks, there's no difference at the perioperative mortality, but a significant difference to surgery later on. So what does that really mean? Well, I've got 4 things that I wanted to say, because I'm sure everyone's got their view. I think the first question we need to ask about the results of that trial is whether or not we now should have a randomized controlled trial. I think that we have some results here which can guide us in talking to our patients, but the propensity analysis cannot control for all the relevant factors, something that a randomized controlled trial is designed to do. We look at these issues that we've highlighted with differences in the neck length and longer-term issues with EVAR. We have to wonder whether an RCT is now justified. This is, I don't think I'm spoiling any data, but this is a recent survey in Europe that said actually most people would now support a randomized controlled trial, which is interesting. Secondly, if we are to use EVAR, off-label EVAR in Juxta renals, we need to ensure it is robust. There's a high proportion of off-label EVARs in this study with inferior results. And I wonder whether it's a practice that needs revising. Do we need to ban off-label EVAR? Are there specific reasons why this group received this treatment, though? There's no other option, perhaps, for them, and that was not identified in the analysis. But I think, should we be looking at more effective methods of off-label EVAR use with specific devices and adjuncts might be the real question here. I think we also need to re-examine who we operate on. There's a very high mortality in those who are high risk from an operative point of view and from an endovascular point of view. There is certainly room, I think, to turn down more patients in the UK. The National Vascular Registry is currently planning a national turn down for AAA audit that will go some way to answering the question. But I don't think we should abandon surgery. Some are claiming that those results are a win for open surgery. I would like you to think of it differently. I think it's naive and backward thinking. I think we need to be thinking, how can we reduce the re-intervention rate? And what is the cause of excess death in the endovascular group? Can we focus our developments to improve it? So, the UK Compass trial, these are my comments. It's fully justified to do the trial, in my opinion, and it was well conducted for what it is. It gives us clear outcomes, but you must interpret the methodology flaws when you look at the outcomes. We can't make broad recommendations for individual patients, but there's key information in there for decisions and consent processes. I think we need to examine who we operate on, consider further studies, and concentrate our efforts to make endovascular therapy more effective in the long term. Thank you very much.
Thank you very much, Dr. Bignell. Next talk will be preloaded fenestrations, advantages and limitations. Dr. Gómez Palones from Valencia. As a consequence of Dana disaster, he will not be able to be in person, but we will contact him online. Thank you very much. How are you doing, Paco? This is Marta Ballesteros.
Yes, thank you very much for your presentation. I want to thank Dr. Alonso for taking me into account to participate in this great meeting. And as I want to apologize to him as well, because not being able to be present at this meeting because of the reason you have already explained. The Dana has had a bad impact in our city and our population. And maybe the conditions here are not the best ones to leave my workplace during those days, so I hope you understand. So I'm going to start the presentation. Okay, this is my topic, fenestrations, advantages, preloaded fenestration, advantages and limitations. Those are my disclosures. The fever has been increasing in a number of cases during a long time, and particularly in the last years. And fenestration allows us to treat a majority of patients with Juxta or pararenal aneurysms. The fenestrations have been increasing in number, including the whole visceral segment, as a consequence of the evidence that the more visceral aorta we include, the less the type 1 endoleaks we have. And as well has been demonstrated that doing 3 or 4 fenestrations, step 1 or 2, does not increase significantly the risk of complications. However, to do fenestration, we still need arterial access, one to introduce the visceral component, and as well we need a contralateral, mainly, or another auxiliary arterial access just to engage and cannulate all the visceral arteries and put the bridge stenting. That means we require proper access, which in the side of the visceral component, it's about 20 French still. And in the contralateral size, particularly when we are using 4 fenestrations, it depends the number of fenestrations and the technique we use, but still require quite a good access to stent all the visceral arteries. That has raised some of the limitations that the conventional or standard fiber, and that's why the preloaded catheter have been able to reduce the profile required in the contralateral side. Preloaded catheters are not new things. In fact, with all the standard device, we still have been using them just to approach arteries which have a very vertical or a very steep downward facing direction in order to be able to accommodate the stents in a more proper size. However, in the recent years, the new platform of Cook, in this case, preloaded, fenestrated, allows us to have a platform where we can preload at least 2 fenestrations with a B-port handle. So it means that with the same side, we are introducing the visceral component, we're able to cannulate and stent at least 2 fenestrations. In this case, the procedure has, first of all, to start with the replacement of the catheter by 2 6-French sheaths. Then these French sheaths can be also punctured with a body wire that goes in parallel with an angiographic catheter that gives some more stability of the sheath attached to the fenestration, and then help us to increase their security and maybe some of the time required to stent cannulate the renal artery in this case. That's the procedure, how it goes. It only has some specifications compared with the standard technique. As always, we start deploying the orientation, the graft, in this case using the fusion technique. The catheter is replaced by a 6-French sheath. The 6-French sheath is then punctured laterally at its valve with a body wire, 018 wire. That's how we proceed. This wire is the one who acts as a body wire, giving some stability. And as well, in parallel, we introduce a catheter which used to be, in most of the cases, 5-French Banshee 3 catheter. With this in place, we are able to cannulate the renal artery in this case, progress the catheter, exchange the hydrophilic wire by a Rosen wire. And once we have done that, remove the body wire, by the way you are seeing here, and then to advance the 6-French sheath inside the target artery. The procedure is repeated the same way in the other fenestration, and the other fenestrations are catheterized from another place, usually the contralateral sheath, but also can be engaged from above. Which are the advantages of this platform with these characteristics? The first one is that we can allow to cannulate and reduce the requirements of the contralateral sheath, like in this case, for example, with a very small aortic bifurcation, where it's no room to allow a 20 French sheath for the delivery system, another 20 French sheath, which was the current one for the 4 fenestrations. So in this case, one side for the visceral component is used, and in the other one, we're currently using a 12 French sheath for 2 fenestrations. In this case, obviously, even though we were able to engage the visceral arteries from both sides, we require to extend that with an orthouniiliac system, because the bifurcation with only 12 millimeters and perimetral calcification was considered not possible to deploy their bifurcated distal component. Other cases where we have a completely occlusion of the left iliac artery, also in this case, the patient is also with a femoral bypass. We also had the option not only to have 2 fenestrations from the delivery system, but 4. 2 of them were engaged from above, thanks to this system where the catheters exit the renal fenestration and then enter inside the SMA fenestration and celiac trunk fenestration. The catheter allowed to send a wire upwards and then engage them, snare them, and go from above with a sheath just to catheterize the remaining arteries. So with no contralateral femoral artery, we managed to perform this case. In other cases, the reason is to have more than 4 visceral arteries, and then all of them from a contralateral side are too much to engage them, all of them in one side. So in those cases, we can use also the preloaded grafts combining fenestrations accessing from below and other from above, particularly in this case where the iliac was really tricky at both sides. And even though we were using preloaded graft, we required to use an exoconduit for one of the sides. That was the final result of this patient with an endoconduit and retrograde perfusion of the left internal iliac artery. But those are the main advantages we find in this particular setting. But there are also some limitations with preloaded fenestration. One of them is we still need a femoral access that allows a 20-French sheath. That is the one, but I think that's something somewhat room for improvement of this profile, but it's about to come maybe in the next years. But the limitation have not only the ones of the standard fenestrations, but also requires some specific material, which is usually available, but with the length and the size and the shape of the catheters, there are not so many options with shorter catheters. First of all, we need a 6 French 90 centimeter sheaths that limit us the use of covered balloon expandable stem larger than 7 millimeters. So that can be used for fenestrations with less than 8 millimeters target arteries. The other side is that we need also catheters that long enough to accommodate to these long sheaths, and maybe more than 110 millimeters would be the option. But in this length, 4 or 5 French catheters with the usual proper shape are not as so many options as with shorter catheters. Also, for the stent and balloon shaft should be also larger ones. Another possible issue that we have found with in this setting is that the system requires, once the graft is deployed, just to remove everything, but we cannot remove completely the top cap unless the fenestrations that are preloaded are also removed their sheaths and catheters. In this setting, we have some problems, and that's if we follow the instructions for use, where the top cap is at the level of the renal fenestrations in this case, and that when we perform the flaring, the balloon of one of the stems can protrude and move and squeeze the top cap against the contralateral renal artery. That may cause the dislodgement or some kind of damage of the contralateral stem. So in our current practice, we are not doing this point. We are not retrieving top cap until this point, which is not possible to be removed at all. We leave it at the top, and one have finished with the renal arteries in this case, remove their sheaths and catheters, and then remove everything from the top, and then continue with the additional fenestration. So that's one of the points we have been more interesting just to highlight as a problem, which is the experience with preloaded catheters. In fenestrated preloaded fenestrations, there was a preliminary study in 2017 which showed that maybe they performed quite similar as the fenestration, but reduced the operative time, also radiation and contrast media. Besides, it allows to face the problem of iliac arteries problems. There's a learning curve anyway in this experience, although it was carried out by really experienced teams. A more contemporary work where the American consortium was involved, and we were happy also to participate with our experience by this time. They enrolled about 712 patients. 30-day mortality was 3.7%, technical success 97%, and also it was considered it performed fine compared with the standard fever. In our current experience, we have the last 3 years, we can account for 40 cases, most of them male, age average of 73 years old. All of them were Juxta pararenal, but 3 of them were thoracoabdominal aneurysms. A total of 157 fenestration, that means about 4 per each patient. 85 of them were preloaded, that means more than 2 per patient. And we carried out the use of preloaded fever because of different reasons. The main one was iliac access issues, like, for example, explained before, occlusion or severe stenotic of at least one side. In other cases, because they had supernumerary visceral arteries, more than 4, in 15% of the cases. Another, we considered this option because they had very steep downward-facing visceral arteries, and other for different reasons, but most of them is that it has become our preferred option whenever possible because we find it really useful and really convenient. In this experience, we had a 30-day survival of 97% with no spinal cord ischemia and levels failure for 1.1 days. We compare that with a historic experience with a standard fever, which is somehow biased because there's not the same period of time. It's not the same experience. It's not the same facilities of Israeli facilities. But overall, it showed to be not a worse experience compared with that, even though we also experienced some improvement in the operative time, reducing the radiation dose and also the reducing the iodine contrast use. There was no difference in 30-day mortality, but these new devices allowed us to carry out the process in really cumbersome cases for a standard fever. So in conclusions, dear colleagues, we find fever has undergone significant improvements in the last years. Preloaded catheters are one of them and allow us to overcome some of them and improve performance. However, there are also options we were formerly using that now can also be used when we feel more comfortable with the preloaded systems. Large series have proved that to be safe and effective, preloaded graft has become our preferred choice in daily practice when implanting fever whenever possible. There are things we have been able to carry out in the past, but now when we use currently, it's like things, once you use them, you can't live without them. Thank you very much for your attention.
Thank you very much, Dr. Palones, and all the speakers for your excellent presentations. Any questions from the floor, first of all? Dr. Gambau?
Excellent session for sure. I have some questions for, probably let me to start with Paco because he's on the screen. We're going to start with that. So the preloaded device is quite interesting for some anatomical reasons, but I have another kind of limitations because when you lose the wire, when you lose the catheter, trying to cannulate the visceral renal artery, for instance, you need to restart again, and so all the advantage you had with the preloaded, you lose it. This is one of the disadvantages. Another one is we are using for all the fenesthetic cases since some years the steerable catheters, 6.5 French, Oscar or Tour-Wide. That is not compatible with this particular technique. And for us, very helpful. Even we don't need to use, even with very deep angulated face down vessels with the steerable catheters, you can solve the problem. Another question or limitation is why not to go from the top, from the arm, rather to play all from below?
Thank you for your question. Very interesting ones. Of course, I have not go in the alternatives, but of course the flexible steerable sheaths can also be an interesting option, particularly in those downward-facing visceral arteries. I agree with this option that would allow us to avoid maybe going from the arm. But the option, the incidents you have described, that losing the catheter, of course, is one of them. You have to restart, but there are also other options you can manage. Maybe you can dedicate the preloaded catheter to use for another visceral artery, and then use the preloaded one engage the preloaded one, have you lose the catheter from the contralateral side. Of course, there are different options. You start from the beginning, it adds some additional time, but that's something is the same you lose the wire for another artery. So of course, it's an option. You have to work hard to avoid it, but maybe it's a It's a drawback, but it's not very common. I have only considered that in one case, but of course it's another option. Going from below is not always the purpose for the reloaded graph. In fact, in some of the cases when you have contralateral occlusion and you need to have with forward fenestration, you need to also go from above. It's not something that precludes any other option. Of course, if the process is not the best one, you can add some complication, but that's something you have to face that with this device and with other ones. But I also understand and I also share with you that there are different options that you don't need to go with the preloaded graph. But in our experience, we also consider the other ones. But still, it's a very convenient option for us.
Dr. Gargiulo, please.
Thank you. And my question is to Colin. Thank you very much, Colin, for the presentation of the trial and the results that you reported. But it's very important, I think, your final take-home message regarding the endovascular therapy, regarding the mortality of the endovascular therapy. Do you think that we follow very well the endograft, but we don't follow very well the patients? We need to improve the cardiological follow-up of these patients. What is your idea for the future to decrease the percentage of mortality in our patients?
So I think you've hit the nail on the head with your question, really. We don't really know what the main factors are in why there is that excess mortality from that study. And I am sure that adequate follow-up, treating those complications early. We know that lots of them are going to need to go back to theatre, but treating them early and effectively and getting it right would be the key. Making sure we operate on patients with good anatomy for that, and all the other things, risk factor control and cardiology, and we should be able to improve a lot of that mortality, shouldn't we? I can't believe that it's patients dying from major complications that early after fever for juxta renal aneurysms, but I don't know.
Dr. Riambau again.
About the spinal cord protection and spinal cord ischemia prophylaxis. So you are using for sure spinal cord selectively, spinal cord drainage selectively, not for all the patients, I believe. For open, probably more than for endo.
So we use spinal cord drainage, CSF drainage for all open patients.
Open.
100%.
And for endo?
And for endo, it's decided at the end of the case.
Yeah.
So at the end of the case, we wake the patient up, and if the patient's moving their legs, then we don't put in
no prophylactic, just depends of the situation.
Yes, okay. Yes. But we've had delayed spinal cord ischemia in 1 or 2 patients where we've had to put a spinal cord drain 24 hours after the procedure.
So I saw in your slides you are using the LicoGuard. This is a dedicated device for that.
Yes.
That makes a lot of difference when you compare, when you analyze all the papers published in the States, because in the States it's not available. So all the papers coming from States talking about the spinal cord protection doing or using or not drainage are a little bit biased because they don't have this particular device. So it's in terms of when you review all the randomized trials, or not randomized trials, all the meta-analysis or systematic reviews, is a lot of bias because the device is not there.
Yes.
So because the anesthesiologists from here make a lot of reviews, but all the papers coming from States are misleading us because it's not just the technique, it's also the method you are using for that technique,
Thank you for the question. When I was preparing this discussion, I looked for a video for Adam Beck from the United States, and they started to use a LicoGuard system in the United States some months ago, and they said that it was a game changer for them because they can target the pressure of the system. They are not drained by volume, they start to drain by pressure, It's the same as in our case. We also use liquid systems from some years ago, and it's a safe device that you can target just what pressure you want and the amount of volume you want to drain. And you can reduce the risk of subdural hematoma, for example.
Yeah, for sure. Finally, they adopt this particular device because it's dedicated for that particular purpose. Another important, I think is important to emphasize that the spinal cord ischemia is not just a spinal fluid pressure. It's the hemodynamics, it's a hemoglobin level, it's all the, it's a multifactorial effect. Yeah.
Thank you, Zorienbao. I have a question too for all the roundtable. Regarding legal implications, if you in a T-bar, because we have not enough evidence, in a T-bar you don't use it, and the patient has a paraplegia, a permanent one, who makes the decision not to put? The surgeons has something to do. The anesthesiologist is doing the technique, but the decision is agreement, not agreement, and who makes the final decision, and if the patients go against the hospital, surgeon, anesthesiologist, so it's not better to try to do more prophylactic technique than to be exposed to this thing?
Is that me?
No, it's for all the table. So who makes the decision to put or not to put? Who is in charge of this decision?
So in our hospital, for the open aneurysms, there is a blanket rule that they will all get a spinal drain. There is no argument, there is no discussion. For TIVAs, the decision is made by the surgeon. Yes, because they know the anatomy, they know exactly what they're dealing with. And we've had drains put in immediately after the procedure, within minutes, when the patient wakes up and can't move his or her legs. And in the risk balance ratio, we prefer it that way, because spinal cord drainage or CSF drainage carries its own significant risks. So if the risk of paraplegia in those cases is not that much, it's not overriding as is in the open, then we leave it up to the surgical team to decide.
In our case, the decision is made by the vascular surgeon in charge of the surgery. We use spinal drains for all open thoracoabdominal aorta surgery. In some cases of T-bar, and the decision is done by the surgeon in charge, and we usually use it without, but the decision, I can remember in the last few years just to use one case, just to therapeutic T-bar, but the problem is the timing with the heparin and the coagulation, because if you do it before the induction, you have a good coagulation and you have not under heparin. But if you do it after the surgery, you don't know, you can have problems with also the coagulation and the timing of heparin.
Well, I think the decision to use drainage of liquid have to be a decision with the surgeon and the anesthesiologist. In my opinion, they have to work in a very close team and discuss every case. In our experience, a week before the surgery, we have a meeting together, surgeons and our anesthesiologist, and decide how we are going to work with this case. For example, we usually in complex cases we prefer divide the procedure into a step, and we will have one leg without catch, and 2 or 3 weeks later we complete the procedure.
Thank you very much.
My opinion?
Okay.
No, just I think the question it means that who's going to pay the compensation, whose insurance company or who's going to jail. But in our case, we share all the opinions, And in the end, maybe the surgeon's one is maybe the strongest one, but have not find any kind of discussion of different points of view with the anesthesiologist. So we share the same opinion, so should be shared the responsibility in the end. So both informed consent, even the one from the anesthesiologist and from the surgeons, are also relating, explaining the advantages and disadvantages of using or not a spinal cord ischemia. So maybe it's a shared opinion.
Thank you very much for your presentations. We are going to close this session. Thank you.